It's an honor to present here today. I'm going to be talking about telepractice research for speech language pathology. It's only going to be a 15-minute overview. So I won't, as in Andy Warhol's 15 minutes of fame, I won't be divulging the details of every single slide, but you'll have them for reference, okay? So here we go. Conflicts of interest. The major one is that I'm receiving a fee for this conference and other conferences and book royalties. This presentation really represents what I'm seeing in 2021, in early 2021. It should not be construed as legal advice. It's a complicated and very changeable environment. So here are the things that we're going to go over today. We're going to discuss the nomenclature of telerehabilitation, and we're going to talk about environmental challenges, which are pretty wide. I'm going to show you an exemplary multidisciplinary research team to model future efforts on, and then identify future research needs for telepractice. So nomenclature, it matters what we call it. You know, black bean soup is not the same as chicken noodle soup, obviously. And teleterminology is really inconsistent. It's because the discipline is emerging. Some call it telemedicine. That was really the origins of this. Telehealth is preferred by the American Occupational Therapy Association. Telerehabilitation, today's term, that's a very all-encompassing term. And then teletherapy is often used for those in special education. So why did ASHA, the American Speech Language Hearing Association, choose telepractice? It's because the association did not want to rule out health-related practice. The profession works in medical and non-medical sites. Some other terminology that is used is telespeech, teleaudiology, and tele-AAC. That's the last one's emerging. That's assistive and augmentative communication. So telepractice does not include telesupervision and distance education, according to ASHA's definition. So why is this terminology problematic? Well, it perpetuates professional silos. It's really important when advocating for reimbursement that the correct terms are used, and that now we're using a broad range of terms. You know, in the past, speech language pathology suffered greatly because a comma was misplaced. And then lots of us publish with other professions. You know, what do we call it? If I'm publishing with an occupational therapist, she wants me to call it telehealth, and I'm looking to call it telepractice. So we usually settle on the first author's profession and where it's going, what journal it's going to. So let's talk about environmental challenges. The environment is incredibly complicated. We are all ruled by insurance companies and healthcare systems. Then there are the state professional licensure boards that tell us what we can do and what we can't do. Professional associations are getting in the mix. Then we have trade associations. The federal government, now that it's looking extremely popular, we've seen reports from CMS, FCC, FDA, all the regulatory agencies are getting involved. Then we're seeing the State Governors Association. About 10 years ago, they issued a very nice report on this. And then we're seeing lobbyists, and that tells you that there's a lot of money at stake. So yes, there are mega investment dollars in telemedicine, and that is, telepractice kind of rides in the wave of telemedicine. So when we see a huge amount of money in telemedicine, we're starting to see companies of interest interested in the income in telepractice. We're talking millions and even billions of dollars. So why is telespeech research kind of nascent? Well, one reason has to do with university priorities. The research hires in telespeech are not the norm right now. You don't see a lot of job postings with that as the primary focus. And faculty expertise is really needed to advise doctoral student tele-research, and they're the research of the future. They're also, doctoral students are needed to help faculty members do their research in their labs. Is tele-research a pathway to tenure? I'm often asked to comment on someone's tenure packet. I've only seen that happen once. Is the research currently transformational? That to me is a huge issue versus proof of concept. Oh, it works well or as well as in-person treatment. And look, systems are prioritizing large research grants. That's understandable. So then we look at the curriculum, and telepractice is often not a core course. I've been fortunate to teach as part of a telepractice course, and I taught an entire group of teleaudiologists, which was really fun. But in general, it's not a core course in the curriculum. And the training in telepractice is not yet critical for accreditation in the profession, nor is it included in the professional examination. There's also indirect negative influencers. So the clinical reimbursement is not consistent or robust. And so clinics, university clinics are not really highly motivated to do this unless they're not making income generally. State licensure barriers are a big issue. And that's a barrier to profitability and practice. And one of the axioms these days is that one state, because each state has its own particular requirements. So also technology evolves faster than all of the following. It's faster than policy, than regulation and ethics. Training lags behind technology development. Professional trust in the technology has to be developed. The consumers need to develop trust in action, ask for the modality. And then the issue with resources and payers. Now, you can look and see it's not that dissimilar from what we're experiencing now with vaccine acceptance. So now I'd like to show you a very prolific multidisciplinary research team. And this is an example at the University of Queensland, so it's university-based. And I've known they've been in business for at least 10 years. They are jointly run by a speech-language pathologist, Dr. Theodoros, and a physiotherapist, as they call themselves in Australia, Professor Trevor Russell. Dr. Ward and Dr. Hill are two of the main researchers, but there's like 10 total faculty staff. So this is not just one faculty member working by themselves in a university, which is often the case in US universities for telepractice, but we have like a corpus of people, and they've been together a long time, and they have doctoral students, 5 currently listed on their website for PhD students in speech-language pathology and 4 in physical therapy. So if you look at some of their projects, and this is, there was actually a second slide, but for time purposes, I'm not going to include that, but you can look on their website and see all the different research possibilities. There's research for Parkinson's disease in the home, mobile technology, how this looks in a hospital department, smartphone applications. I'm seeing apps as a subject of research in a few places in the United States. What about non-progressive dysarthria treatment? That is looking very successful. Online aphasia groups and emotional literacy in children with language impairment. So there's a whole pediatric side to this as well. And you don't see as many exemplars for the physical therapy part of this, and there's none posted for teleaudiology, which is interesting because everything can be done on audiology that's done in the clinic, as long as there's a computer-based equipment. So now, what are the future research needs? Well, we do know that the evidence for telepractice is developing. It looks equivalent, and it's sometimes superior in terms of clinical results. And that's why the wisdom is charge as much for telepractice as you do for in-person treatment. We know from Lynn Covert's work that it saves travel time and money for consumers. And if you want to access research, there's a very good site for the American Speech Language Hearing Association that presents evidence maps, and it's updated. And you will, there's a lot of journal articles that are free from the American Speech Language Hearing Association. The problem is that the studies are not robust. And I can attest to that as a journal editor. We refuse many more than we publish. There's a lack of control groups. There's a lack of randomization. Some, especially in other countries, don't present IRB approvals. Some don't go along with HIPAA requirements. The population study are often heterogeneous, so it's hard to generalize from one to another. And some mix the technologies and the environments in one study. So it's very hard to get a pure study. And look, here's all of the environments that we just, there's probably some more, but you can have telepractice happening anywhere there's a mobile device. And so I see work in schools and in homes, and hospice is starting. Universities can be doing research even in a room next door. It's not in the same room. And the military have been especially impressive in terms of their developments with telemedicine. Correctional facilities, that's called the low-hanging fruit because people feel that there's income attached to that. That's really a need. And then we see where kiosks are expected to become more prevalent in malls and in pharmacies and in big box stores. When you see Walmart getting excited about telepractice and telemedicine, you know that it's here to stay. And then transportation. Remember those space shots with NASA? That they used telemedicine a long time ago, and they're doing it in all over the world, and not only to help our soldiers if they are injured, but also to as a preventative kind of medicine. Some celebrities have telemedicine on their school bus, on their tour buses. So now here's some research opportunities, and the ones in orange are actually the ones I see as really hot. Artificial intelligence. We're not really sure what that means yet for telerehabilitation, but that's developing. And some of the leaders in telemedicine went off and formed an AI company. We also hybrid telepractice. When is there the need to see a patient in person and also and the availability to use them for telepractice? So what's that combination, and how effective is it? Multicultural factors, okay? Patient selection. A lot of people say, well, I'm not going to work with this person or that person because of their disorder and their severity or the behavioral problems. But we find that when there's a clinician that was really skilled in those areas, it can go very well. Privacy and security is important, but moving down again to the hot things, virtual environments, simulations, and gaming. Let's look and see what 6 and 7-year-olds are doing, and that's going to be the future of telepractice. Now, I also want to mention the economic impacts on healthcare and the workforce, because there's some companies that are paying very little money per hour for clinicians, and they're not giving benefits, and it's not a stable kind of life. And that's a problem because as this becomes more pervasive, it could really affect salaries across the board. So what are the research needs right now? We need more research funding. We need those sustainable faculty positions, not just one in a university, but we need a corpus. Maybe in a school, we need interdisciplinary teams. And that's where I got my start from the Department of Education's telerehab groups. And we need to have more rigorous research, okay? And the consumers should be driving research, as in PCORI grants, and that's a fair amount of income. So what we need to have that evidence-based translational research that leads to technical standards and guidelines. A lot of professional organizations are not happy about putting out these because they feel that they get outdated, but that's what we need. So in the future, if you're doing research, you'll be famous for 15 minutes. And if the principal calls, it's probably about my 15 minutes of fame or shame. So I encourage you to think about doing research in telepractice. It's a really wide open field. And it's very exciting, and it's unimaginable what could be done.